All right, welcome everybody. Woo. Welcome back, I should say. So we are on the home stretch here in the Amygdala conference for 2019. It is my pleasure to introduce our final speaker of the day. Just to give you a roadmap, Dr. Lucki will speak. We will quickly set up for the moderator section. I'll bring down our moderator leader, and then we'll have some closing remarks by Dr. Sano. Okay, so without further ado, I'd like to introduce Dr. Irwin Lucki, who is from our Uniformed Services University, and he is the chair of the Department of Pharmacology and Molecular Therapeutics, and will talk to us about the preclinical development of ketamine and other derivatives for depression and other disorders. Thank you, Dr. Lucki.
Hello. Does this work? Okay. Good afternoon, everybody. It's been a remarkable day, because when you think of the range of approaches that are incorporated by the Amygdala conference, I could only congratulate the organizers for the breadth of their vision, bringing in those very poignant memories from Dennis Charney this morning, the pearls of wisdom of treating sleep disorders that we heard about, and the listening to the interpersonal relationships, the hints of how to evaluate interpersonal relationships and stress that we just heard about before. To me, I am a preclinical pharmacologist that has studied the effects of antidepressant drugs for his entire career. And I'm going to talk to you about the efforts in our laboratory towards understanding ketamine as the next transformational treatment of depression in psychiatry, and perhaps going beyond ketamine towards what we hope will be an even more valuable compound, the metabolite HNK. So this is my disclaimer, and I have no conflicts of interest. These are the learning objectives that you've seen, and I have a confession that the knowledge statement on one of your knowledge statements, the answer is now wrong. So everybody write that down, because the answer to is ketamine is widely used to treat depression and has been approved for that purpose by the FDA was incorrect at the time that I wrote it, but it is now correct, okay? Because we've had the approval of an intranasal version of ketamine. Just in case Bob is testing you. So we study depression because depression is one of the most prevalent of the psychiatric disorders in the world, and causes the greatest economic burden out of all psychiatric disorders. It's estimated in the United States that there are 17 million adults struggling with depression, and a substantial number of them, 11 million of them, are estimated to receive some kind of medication as their form of treatment. And if you get medication, then most likely you're getting medication, as we discussed this morning, of one of the conventional antidepressants that were developed over the years, because they're able to inhibit the reuptake of norepinephrine and serotonin. There's several dozen of them available, and they all are effective at helping people, and about 50% of people experience at least a temporary reduction of symptoms. But of them, only 30% of patients receive treatment for depression that would reach a point of remission. So the drugs are effective at helping people, but they're not as effective as we would like them to be. And out of these folks, about 30% of them have tried multiple kinds of antidepressants and they fail. And if you fail to 2 different kinds of antidepressants, you now are labeled as treatment-resistant, a treatment-resistant form of depression, a form of depression that involves depression and anxiety and carries with it a high risk of suicide. And in addition to depression, these other psychiatric indications are also treated with antidepressants, but they're not treated very effectively. Suicidal ideation and post-traumatic stress disorder. But the conventional antidepressants is all that we have for treating depression. Until perhaps recently, there has been a lot of attention now paid to the development of ketamine. And ketamine is an old drug that was developed in 1958 by a drug company called Parke-Davis that's located near Detroit. And they were looking at a number of compounds, including phencyclidine, as novel anesthetic agents. And they developed ketamine, and a number of University of Michigan pharmacologists worked on the development of ketamine over the time. Ketamine was developed as an effective anesthetic agent, and it's probably the most widely used anesthetic agent in the world. And so it's very effective, and in fact it rose to prominence because the military used ketamine very effectively in the Vietnam War, because it was in operational theaters, it helped to produce sedation without producing respiratory depression or and provided hemodynamic support. So what we've seen is the development of ketamine for anesthesia, but more recently what's in the news is that ketamine is being used widely for the treatment of other psychiatric conditions like depression. And this is, ketamine has been used in ketamine clinics and has to be administered by intravenous infusion for the treatment of depression, and also it's being used in the treatment of some chronic pain syndromes as well. What we've seen in the last month or so is that the FDA approved a new form of ketamine, the S-ketamine, S isomer of ketamine, in this form for intranasal administration. And it's not yet available, but it will be available in the coming months. And we have to, and there will be instructions on how to use it very effectively so as to avoid diversion. And studies are still being done in order to demonstrate conclusively its effectiveness. So ketamine is a potentially transformative drug for the treatment of depression because at low doses, the racemic version of ketamine, infusion of it, causes rapid antidepressant effects in treatment-resistant patients. There are widespread reports that back up this claim. It produces a near immediate onset, and it effects from a single infusion last for between 4 to 14 days in a subject. So that's extraordinary, and I want to just emphasize that because the half-life of ketamine is about an hour. So at the time of the end of the infusion, ketamine won't last in the body very long, but it produces a series of plastic changes that persist beyond the presence of the drug that are correlated with behavioral improvement. And understanding this action of the drug is where we're at in the pharmacological development of ketamine. It also rapidly reduces suicidal ideation, creating now for the first time the possibility that drugs could be used in concert with other treatments to be able to protect individuals from suicidal ideation. And as we said, S-ketamine is approved by the FDA for the treatment-resistant depression, now given by the intranasal route. And this is some data from Carlos Zarate that Dennis Charney referred to this morning. And I'll just walk you through the slide because it really shows you very nicely why ketamine is such an exciting drug. Ketamine as an infusion is being given as an infusion to treatment-resistant patients. And no effect at 40 minutes, but effects begin at 2 hours, and then at the end of the day, 70% of patients responded with a positive response. One day in treatment-resistant patients, it's really like a miracle. This is comparative data of conventional antidepressants given to treatment-resistant patients showing that they don't produce much effect, nothing like ketamine. And here, this is the scale for suicidal ideation, demonstrating equivalently that infusions of ketamine can produce very rapid reductions of reports of suicidal ideation in these treatment-resistant patients. So ketamine can produce these rapid effects as shown by the NIH. But what will they do in your hands? And so it doesn't always work this way. It could work perhaps less well. And this is data from a publication by Singh looking at the way that ketamine is probably going to be used in the future, which is by repeated dosing. So they treated treatment-resistant patients with twice-weekly dosing, twice a week, or 3 times a week. And if you look at it, this is like a Monday and a Wednesday and a Friday, and then the weekend, and then a Monday, Wednesday, and Friday, and we're taking a look at the treatment effects that occur. And you can see that on the first exposure to ketamine, that the effect was about 50% of that it will eventually achieve with repeated exposures. So it's to say that perhaps the excitement about ketamine being given only once and then having patients leave is misplaced, that we really need to think more concertedly about repeated exposures of ketamine. And in fact, the instructions for the use of ketamine, or if you go to a ketamine clinic, is that you get 6 exposures to ketamine given every other day to be able to load up with the effect of ketamine. And the reason for that is because they reported that patients that responded or remitted maintained the efficacy of ketamine for a 4-week follow-up under either of these treatment regimens. So instead of it disappearing after just a few days, if one gives repeated exposures to ketamine, we can extend the period of efficacy of ketamine for several weeks. And this could allow ketamine to be used perhaps with repeated boosters at times to be able to treat patients for a longer period of time than we originally thought. If it was just good for one exposure, it would become more like a boutique drug rather than a real medicine. So I included another study that I find interesting, the Albert study that was just published last year, looking at comorbid chronic PTSD and treatment-resistant depression. They had separate scales for PTSD and for depression in their study. This is just the MADRS for the depression scores that I'm showing right here. And during this induction period, they also used the every other day for 2-week period of induction to be able to treat their patients. And what they see is something very similar to what I described before. There's an effect on first treatment, but the effect intensifies with repeated exposures. And then they looked at relapse over a 50-day period of time. And they find that these are the proportional relapses. But if you look at 2-3 weeks, a substantial number of the patients retain the efficacy of ketamine after this repeated exposure period, showing a way that we might be able to use ketamine more effectively in the treatment of depression. Most of the animal studies that in the world that I work in had focused on single administration of ketamine. And so this became something that we were very much interested in, is using a kind of a feat of reverse translation, if you would, to be able to evaluate the effects of ketamine after repeated exposure. This slide summarizes a little bit about what I'm talking about here. Is when you give ketamine, in the 30 minutes, you'll experience acute responses to ketamine that are both a dissociative mental state, alterations of mood that are produced by the NMDA receptor blockade. But what ketamine produces, what we're interested in, is the antidepressant behavioral effects that are launched from this period of time that persist for a longer period of time than the physical presence of ketamine itself. And if we give repeated ketamine injections, we expect that these effects are going to persist for an even longer period of time. So in my world, the way in which we study the effects of novel antidepressants is to use models of behavior that they're responsive to. And this is one of them that is most popular. This is the forced swimming test, a test that I've worked on for quite some time. And in this test, a mouse or a mouse here is placed in a cylinder of water. And initially, he attempts to escape from the cylinder and get out as rapidly as possible, because that's the only means of escape. And after a period of time, so this is the swimming mouse, and then after a period of time, he transitions to being an immobile mouse, because after his attempts to escape are fruitless, then he just settles into a period some people have described as helplessness, but it's really, what we're talking here is a transition between active and passive coping responses that we've heard about all day long. During the active coping response, during the early period of time, the animal is intent on making escape attempts before he transitions into a passive coping strategy, where he just is making sufficient movements to stay afloat. What antidepressants do as a class, and this is what's remarkable about them, is what they do as a class is that they facilitate the active coping response and diminish the passive coping response. So animals persist in trying to escape from the cylinder for a longer period of time before they transition to the passive coping response. All antidepressants do this. And so we explored the effects of ketamine in mice to be able to characterize this. And in fact, ketamine, so the effects of ketamine here are shown by reductions of immobility that we measure in the forced swimming test. And we did a dose response curve for the effects of ketamine, and we have various doses that have been identified. But what's different about ketamine than other antidepressants in this figure that may not be obvious is that we're looking 24 hours after administration of ketamine. And ketamine is long gone from the animal. So this is a recapitulation of those protracted effects that we were talking about that occur in patients. That ketamine is administered, and days later you could be able to still see the effects of the plasticity changes that have been produced by ketamine. This is a study where we looked over a time course of after administration of these doses of ketamine in mice, and we find that the drug was effective at 24 hours and 48 hours, but by 72 hours, the animals had returned back to normal. So we were interested in what happens if you give ketamine repeatedly, and in a kind of a reverse translation, what happens with ketamine given repeatedly to the duration of action of ketamine. And so what we decided to do is to compare the effects of giving ketamine only as a single administration with giving ketamine 3 times spaced by 48 hours in a way to simulate those treatment effects that I showed you just a few slides ago. And what this slide shows you is that on the same test is that 24 hours after administration, ketamine was effective. But 1 week later, if ketamine was given 3 times, the effects persisted beyond 1 week, and by 2 weeks eventually disappear. So it shows that there is value in this repeated exposure procedure. There's value in the giving ketamine with a spaced presentation to be able to prolong the effects of ketamine, and this could be replicated in an animal model. But let's not get too complacent, because the effects of ketamine may be dependent upon the spacing of the model. So in this particular experiment, we decided to try to load up mice with ketamine by giving them 3 injections of ketamine, but all within the same day. And so if we do that, what you see is that this doesn't work. So it's not 3 injections of ketamine, but it's 3 injections of ketamine spaced appropriately apart to be able to produce a prolonged plasticity that winds up producing the elongation of its effects. What's the mechanism of this is something that our lab is currently investigating. And what we do is we're taking these animals, we're looking for molecular changes in their brains to give us clues as to what it is that we've done in order to produce this prolonged plasticity over this long period of time. Another model that's used is called the novelty-induced hypophagia test. And novelty-induced hypophagia, first we train a mouse to eat something really delectable, like a peanut butter chips. And so we give mice peanut butter chips in daily eating sessions, and pretty soon they understand that the Petri dish is going to contain peanut butter chips, and they go and they ingest them within 30 seconds of exposure. And you can see what happens here. This is the home cage, and when mice are now given an opportunity to eat peanut butter chips, you can't even see the latency, it's so quick. But now if you take them and you move them to a novel cage, all of a sudden they don't want to eat those peanut butter chips anymore. It takes a long time for them to approach those peanut butter chips. And that's called novelty-induced hypophagia. So that you can see here that mice will take 15 minutes to approach those chips, whereas ordinarily they would be eating those chips in 30 seconds. The reason why this model is so important is because it's been used to study conventional antidepressant drugs successfully. And what it does is it models conventional antidepressant drugs by capturing the fact that conventional antidepressant drugs require weeks of administration before these effects will occur. So let me show you what the effects are. This is the effects of ketamine, and ketamine is producing a reduction of the approach latency, so they can counteract the effect of the novelty at slowing down the approach towards feeding in the mice. And so conventional antidepressants like fluoxetine and venlafaxine and other compounds will also do the same thing, but they require 3 weeks of treatment to do it. And in this case, we're using the model to be able to show you that ketamine produces the same kind of antidepressant effect only immediately after injection, but at a period of time when ketamine is no longer physiologically present. So how does ketamine work? Ketamine is an NMDA antagonist, and it's most often described as that is the mechanism of action of the drug. But our suspicions are that the effects of the drug are much more complex than that. So let me take you through this slide. This is a penultimate glutamate neuron. Glutamate is being packaged in synaptic vesicles for secretion across the synapse to activate postsynaptic receptors. But this neuron is also innervated by a GABA inhibitory neuron to produce regulation of its activity. And this GABA neuron contains an NMDA receptor. So the thinking is that ketamine interacts with this NMDA receptor to block it. And it produces a sort of disinhibition phenomena because the inhibitory neuron is being blocked, so it no longer produces an inhibitory action, causing the release of glutamate across the synapse onto the AMPA receptor. And when the glutamate then activates the AMPA receptor, it produces a cascade of signaling effects and neurotrophic secretion that may be involved in the behavioral actions of ketamine. So the things that we'll talk about in the next couple slides, or just get listed, are increases of of signaling produced by AMPA receptors to activate signaling, the signaling cascade, the AKT mTOR signaling cascade, a secretion of neurotrophins like BDNF that will activate to produce rapid changes of neuroplasticity. These are the effectors that could produce the long-lasting actions of ketamine when ketamine is no longer in the system. So just to show you that we could use behavior to test this idea, we, in USIS, we pre-treated animals with an AMPA receptor antagonist to block the AMPA receptor prior to administering ketamine. And when we do this, we block the ability, this is NBQX, an AMPA receptor blocker, and we block the ability of ketamine to produce the reduction of immobility. We also block the ability of ketamine to produce reductions of latency to approach on the novelty-induced hypophagia test. And various labs are engaged in attempting to provide information about their particular version of the effector systems that are involved in producing ketamine's effects. And this lecture could go on for a long period of time if I were going to tell you about the 30 or 40 different proposals that have been put forward for what may be mediating it. But it's a very, very rich and exciting area of research now that is coalesced around trying to identify what mediates the neuroplasticity effects of ketamine. So this is an example of that. This is one of the original papers from the NIH group by Autry, showing that ketamine could produce a reduction of immobility on the forced swimming test, but not in BDNF knockout mice, suggesting that BDNF, a neurotrophin that also causes changes of neuroplasticity, may be involved in mediating the behavioral actions of ketamine. This is another example of work that is being done in this area, showing that counting the spines that occur on neurons in the cortex and the hippocampus. And these spines help to facilitate neurotransmission and disappear when animals are exposed to stress. And what ketamine does is it brings them back. And it brings them back rapidly, and they persist for a long period of time. So you could see a whole cascade of anti-stress effects that have been shown to ketamine, acute effects of ketamine, that are persistent in the animal, helping to substantiate the idea that both antidepressant effects in humans and animals are occurring from these long-term plasticity effects. These are some ideas of the neural mechanisms associated with ketamine's protracted effects and behavioral effects that are related to antidepressants and reduced inflammation. We've measured this. Reversals of the effects of stressors, like in the chronic mild stress procedure or chronic social defeat, which produce long-term alterations of stress in animals. These effects are reversed acutely by administration of ketamine. Changes of structural neuroplasticity, like the spines that are associated with cortical neurons that help to facilitate neurotransmission. Intracellular signaling cascades are thought to be associated with the effects of ketamine. And so this helps to give you a little bit of a journey through my world on where we are with ketamine involvement and what ketamine is capable of doing on stress paradigms in the central nervous system. What we're doing at USIS, for example, is we're also interested in carrying forward. I'm going to describe for you a couple of initiatives with ketamine that we're doing in the laboratory before I get to talk to you about another compound, a metabolite of ketamine, that we think might also be involved. So a critical question with ketamine is to identify the neural circuitry that may be associated with ketamine's protracted antidepressant effects. And areas that have been focused on by the preclinical community have been the prefrontal cortex and the hippocampus, because investigators like Ron Duman at Yale and Hashimoto in Japan have put ketamine directly into the prefrontal cortex and can produce behavioral effects from these manipulations. So that became kind of a popular groundswell, and people didn't look at in other places. So more recently, people are looking at other places and finding ketamine might also produce its effects at other critical junctures in the nervous system, such as the amygdala, the nucleus accumbens, ventral tegmental area that mediates dopamine and the critical dopamine reward circuit. And one of the areas that we've been investigating here, and I've been investigating through collaboration with Dr. Ferry Nugent in the pharmacology department, is the lateral habenula nucleus. The lateral habenula is an area that Ferry brought me to, because when I came here, I really wasn't on my radar. But it turns out that the lateral habenula nucleus has become a very important focal point as a potential neural correlate of depression and antidepressant effects. So imaging studies have been done in depressed patients to be able to demonstrate the hyperactivity of the habenula in depressed patients and alterations of the habenula after antidepressant treatment. What Ferry does in her laboratory is that she's interested in a model of rodent maternal care, and she uses it as a model for childhood neglect during development, in which rodents are taken away from their moms for a 24-hour period when they're only developing, and then they're reunited. And it causes lifelong dysfunctions of anxiety and depression as long as the animal is alive. The effects are residual for months long, and it produces a fantastic model for us to be able to investigate the effects of drugs that could be useful in psychiatric medicine. This is the lateral habenula, which is her region of interest. And the reason why she's especially interested in the lateral habenula is because of its connections between lateral habenula and an area called the RMTG that regulates the ventral tegmental area nucleus accumbens dopamine connections that are associated with the natural reward system in the brain. This connection here inhibits the activity of this, and if this becomes overactive during stress and due to stress, then this overactivity will cause an inhibition of the dopamine system and therefore cause deficits in reward-related behavior. So this is an example of her data that was recently published by Ferry and her student Ryan Shepard, who just completed his PhD thesis in the pharmacology department. And you can see here that this is neuronal activity in non-maternally deprived rats, and this is maternally deprived rats. You can see the tremendous increase in frequency of neuronal activity caused by the history of the maternal deprivation that was produced in this animal when it was very young. And the remarkable thing is that ketamine interacts with this burst firing of the lateral habenula by reducing it so as to produce a therapeutic activity. So this is, for example, the proportion of activity in the lateral habenula that is either silent in gray or tonically active or bursting. And you can see in the maternally deprived animals there's an increase of burst activity. And this increase of burst activity in maternally deprived animal is reduced significantly by pretreatment with ketamine. And this is another example of the electrophysiological activity in the lateral habenula, the increase of neuronal activity that is measured here, and the ability of ketamine to produce a diminishment of this effect that could be a source of translation of therapeutic activity. It could also serve as a biomarker in human patients for actions of ketamine that could be imaged. And finally, we gave ketamine to maternally deprived animals with Ferry's that were prepared by Ferry's laboratory. And these are the non-maternally deprived animals here, and these are the maternally deprived animals. And you can see what happens when they grow up. They show not normal levels of immobility, but higher levels of immobility in the forced swimming test. And these higher levels of immobility were significantly suppressed by maternal deprivation. And this was accompanied not by changing levels of climbing behavior, but by changing levels of swimming behavior in these rats over time. So the important thing is that these effects were measured 24 hours post-administration. So again, we're showing that ketamine produces these residual protracted effects in animals, now not normal animals, but animals are reflecting a depressive phenotype at a later period of time, and this depressive phenotype is being counteracted by ketamine administration. Another area of work I just wanted to tell you about that we're doing in our laboratory that is militarily related is that we're examining the effects of ketamine in animals that receive a blast injury. And we think that animals that have undergone TBI, patients that undergo TBI often experience depression. And so we're interested in studying the effects of ketamine in animals that have experienced blast injury. And we're doing this in collaboration with John Wu in the Department of OBGYN. And what we've been able to show so far, and these studies are currently underway, so I don't have the data to be able to show you, was that we are able to produce positive behavioral effects in these animals, but we also have been able to detect increased sensitivity to some of the side effects of ketamine in these brain-injured animals. And so that just suggests that we're going to have to be very careful in going forward and treating these patients because they have brain injury and they may be especially sensitive to the effects of sedative agents like ketamine. So ketamine is a potentially transformative effect in depression. It's the first rapidly acting antidepressant drug, but that's the good news. But ketamine also has a number of side effects that might be especially concerning in its clinical treatment. And it produces, while it's being infused or taken, it produces dissociative, anesthetic, and psychotomimetic effects. It's a hallucinogen. And so when people take it, they have to stay put for a while until those effects go away. And those effects are estimated by the FDA with intranasal administration to last for about 2 hours. And so people will need to stay put and before they could be streeted to be able to go off and do their own thing. So that's a liability of the treatment with the drug. While it's being administered as an amnesic agent, and there's also a societal concern of the abuse potential because after all, ketamine is also known as special K, and many people wind up abusing ketamine. So this is being mitigated because right now ketamine for depression is only available through intravenous use, and the intranasal form will also be under tight controls, and so we could produce regulation and prevent diversion of the drug by means of these controls. But these concerns and others have caused a number of physicians to be cautious about the use of ketamine. So we're interested in whether can the therapeutic effects of ketamine be separated from its deleterious effects. Is there a way in which to identify what's the critical component of ketamine that's producing its antidepressant effects and engineer out the abuse potential and engineer out the dissociative effects and produce a better drug that everybody will be able to use. And we think, and it's not my idea, but this idea was put forward by Todd Gould from the University of Maryland, that one of the metabolites of ketamine may be such a drug. One of the metabolites of ketamine may have all the ability to produce many of the positive behavioral effects of ketamine, but be absent the abuse potential and be absent the negative side effects of ketamine. And so this is ketamine, and this is its metabolic tree, where it is demethylated and oxidized into a number of different metabolites are available, and these are the ones that Todd Gould chose to focus in on: the 2R, 6R HNK, or the 2S, 6S HNK, that derive from each one of the isomers of ketamine. And here's the idea, is that ketamine produces its effects, but the idea is that the metabolite may be the real effector, or at least be playing an important role in producing these positive effects. So let me take you through some of the data. This is data from Gould Laboratory showing that HNK at high doses, either in the R or the S form, can produce antidepressant effects in the forced swimming test. They produced a reversal of learned helplessness effects. Here, learned helplessness is a model of depression where animals are exposed to repeated electric shocks and fail to produce an escape response. And what ketamine does is it restores their ability to produce this escape response, and so does the metabolite HNK at low doses, 10 milligrams per kilogram. And in the chronic social defeat paradigm, this is just the R version of HNK. It was capable of restoring social interaction in animals that had suffered repeated social defeats. And so utilizing this kind of data, Todd Gould has argued that many of the positive effects of ketamine might be recapitulated by one of these metabolites. And the interesting thing about this metabolite is it has very poor affinity for NMDA receptors. So all of the effects that are due to ketamine and NMDA receptor blockade, all of the hallucinatory effects, are not being produced by the metabolite. Here you can see that the HNK does not cause animals to fall off a rotor rod. It doesn't produce the sedation. This is a model of abuse potential self-administration in which a mouse will press a lever in order to receive an injection of ketamine. And mice learn to produce this response and sustain self-administration of ketamine, but not HNK. And in this case, this drug discrimination is also a model that is used to evaluate abuse potential. Mice are trained to discriminate ketamine from saline and make a response on the left bar when they receive ketamine and on the right bar when they receive saline, so as to tell us exactly what they're feeling internally. And from this training, you could then see whether or not they generalize to other drugs. So for example, mice trained to discriminate ketamine would generalize to a similar hallucinogen like phencyclidine. They don't generalize to the metabolite HNK. So at this point, this is where I came in, because I was fortunate enough by being here to be asked to join the NIMH Translational Task Force that evaluates the potential development of new drugs by the NIMH. And Gould's proposal that the HNK be developed was being reviewed by the NIMH at that time. And we reviewed this and we reviewed the Gould data, but at the same time, other groups were reporting that they were not finding the same pattern of results that the Gould laboratory was reporting. And so they turned to us at USIS and they said, well, could you take a look at it? And so by getting drug from NCAS and just performing this service for the NIMH, we got drawn into the ketamine story. And this is data that we produced in our laboratory in order to evaluate the effects of HNK. And we gave HNK either 1 or 3 times in the same paradigm that I showed you many slides earlier for ketamine, to evaluate what it does. You can see 24 hours after administration of the 10 milligram per kilogram dose of HNK, we can produce these positive behavioral effects in the forced swimming test in our hands, because we have a considerable experience with this test. And these effects persisted for 1 week later if animals had received 3 injections. And so not only did we report that both isomers of HNK were active, but both isomers of HNK could also produce the augmentation with repeated exposure that the ketamine itself is producing. So it gives us a way of being able to investigate what are the neurochemical determinants of this potentiated response. Another measure of the effects of HNK was investigated by Mariah Jacobson in the laboratory using the pre-pulse inhibition of startle model. So what pre-pulse inhibition of startle is that if we were to sound a very loud noise right now, you would startle. But if we sounded a tone just prior to that noise, that tone would disrupt the startle response in most individuals, and that's called pre-pulse inhibition. And reason why that's important is because hallucinogens reduce that pre-pulse inhibition, and people with psychosis also have reduced pre-pulse inhibition. And ketamine reduces pre-pulse inhibition as part of the view of it being a translational model of hallucinogenic drug action. And so Mariah showed a very nice dose-dependent effect of ketamine. These doses are a little higher than those needed to produce antidepressant effects, but they're not yet at the anesthetic dosage range, would be about 50 milligrams per kilogram. But HNK did not produce these effects at all. So this dissociation between ketamine and HNK is what's driving us to think that perhaps there is something to this hypothesis that HNK may contain many of the positive effects of ketamine, but be absent some of the negative side effects. And so then the last part of this talk, in just the next couple of slides, is just to tell you about a novel effect that we obtained in the lab only very recently. And through a tip, I heard that HNK may produce analgesic effects, surprisingly 24 hours after administration of the drug. Well, since we've been now primed to look for these protracted effects, this wasn't a crazy idea, this was an important idea. And so in looking up ketamine and analgesia, we saw that, of course, acute ketamine is used as an analgesic post-surgery, but chronic ketamine is used for analgesia even in our chronic pain clinics here at USIS. And in one of the chronic pain syndromes, CRPS, for example, ketamine may be administered repeatedly for 4 days by infusion. And when it was done this way, patients remained pain-free for the next 3 weeks. What's that all about? The drug's gone, remember? So what's causing those protracted actions? So we were very much interested in that, and it could be that a metabolite or this we're tapping into the same kinds of mechanism that ketamine is producing. So we were interested in whether HNK may produce these analgesic effects. And this is the last slide to show you. This was work that was done by John Yost as a rotation project in the laboratory, and it was the most successful rotation project that I have ever been part of in my career. Because what John showed is very nicely is he's measuring the analgesic effects of ketamine and HNK here. And during the first day of administration, within hours, literally within just 10 minutes, this is 0.1 hours, you can get this very robust effect of ketamine as an analgesic in the hot plate assay, but no effect of these 2 doses of the RHNK. I'm sorry, this is RHNK here in green, and SHNK in blue. But if you look 24 hours later, there's a significant effect emerging of the RHNK. Ketamine's gone, not there yet. And 48 hours later, the analgesic effect persists. This is only the second report of this effect. There was somebody else who found it, but we're repeating it. I think it could be very important in identifying a novel analgesic effect without sedative side effects that is not opioid mediated could be very, very important news for all of us. So it's going to be a very successful project that John Yost is able to take on in the laboratory to be able to nail down and investigate these effects with other pain models and looking at the mechanism of action of the analgesic effects of this unusual metabolite. And it's possible that this unusual metabolite may be responsible in part for some of the analgesic effects of ketamine that have been reported in pain models up until now. So just in conclusion, what I've taken you through is data that shows that low doses of ketamine can produce rapid antidepressant effects in treatment-resistant patients. But it's accompanied by negative indications of dystaxia, amnesia, sensory motor gating deficits, abuse potential that have limited its widespread use even amongst the psychiatry community here at USIS. Preclinical studies that we are conducting are interrogating the neural circuitry and neurochemical mechanisms that underlie the effects of ketamine and its metabolites in order to understand them better and to extend them. And one of the effects that we found in support is that the 2R-HNK isomer may retain many of the effects of ketamine, but not those that are related to sedation or abuse potential. So it may be worthy of further development. And in fact, HNK is being developed by the NIMH group that I was affiliated with. It is currently undergoing phase 1 trials to evaluate its safety. Even though people will have taken ketamine for a long period of time and it's a metabolite, they wouldn't have received concentrations of HNK that we intend to administer to patients. And so it's undergoing phase 1 trials right now, and we'll be ready for evaluation in phase 2 trials towards the end of the year with Carlos Zarate at the NIMH. And finally, this protracted analgesic effect of HNK is very, very intriguing. And this may be related to the analgesic effects of ketamine and may be a new addition to our armamentarium of hopefully of non-addictive analgesic agents. Thank you very much. These are my collaborators and their funding sources.